Okay, we're good to go.
Okay. So good evening. Welcome to the second event in Northern New Mexico College's Hispanic Heritage Month and Census 2020 series. My name is Dr. Patricia Trujillo, and I am the Director of the Office of Equity and Diversity, and I will be your moderator for the evening. I would just like to remind everybody in the Zoom world, we have some Zoom etiquette, which is if everybody can mute themselves, and then of course, if you have a question or a comment, you're welcome to unmute yourself to ask it, but just so that we can keep our background noise under control, that will be helpful. Thank you so much. And before we get to our main event, I'm also here just to remind you that we currently have 1 week left to fill out our census. The census efforts have been really at full speed. If you've been driving around town, you've seen that there's been a wonderful Fiesta del Census happening for the last 3 weekends in the Washington Federal parking lot, where we had live music, and it was the only drive-through census event in the country that we can tell. And it was a great success. Thanks so much to the Rio Arriba County Complete Count Census Committee, with it, like special thanks to Audrey Herrera, who organized, to Willie Williams, who was our MC, who did such a wonderful job. If you were driving through town, they were blasting music, engaging people, and we were able to sign up over 960 households during those 3 weekends. And so it was a great success. Percentage-wise, we went from about 26.7% to 30.7%, so we did see an uptick. And so we're excited about that, but we need to see more. In 2010, our Rio Arriba counted at 41%. We're currently at 30.7%, so we're about 10 points behind. But in both of those scenarios, we really want to get to that 100%, right? Or as high as possible, because the census data has everything to do with how our communities are funded. So we really want to reiterate, please, if you haven't done your census, please do your census. We'll have all the information at the end of the program about where you can do that at. But if you've done the census, what we're trying to do and ask community members is challenge yourself. Touch base with 5 to 10 of your friends and your family to see if they've done it. One of the most undercounted groups in New Mexico and throughout the United States are children of color. So please remember that anybody who's in your household, who is living in your household as of April 1st, 2020, is counted. So whether that's family or not, if they're living in your household, you count them. Make sure to count all of your kids, count your grandparents. Everybody counts in the 2020 census. And so we are in the final stretch for this outreach. So I would just like to let everybody know that there is a census code that you can text. This is in particular for the students, staff, and faculty, but community can also use this code. You just need to text the word census help to 3131 for assistance with completing the census over the phone, and I will follow up and put that in the chat. But the number again is 313131, and you text the word census help and somebody will contact you. And that leads me into our introduction for our speaker today. I'm really happy and so proud to be able to uplift and support the work of Dr. Julie Lucero, who is here to speak to us today. She's a fellow Norteña and daughter of the Española Valley. And she's going to be speaking to us about the importance of census data for developing health research and program planning. And in particular, the purpose of this presentation is to provide examples of how census data are used to develop public health research and programs for Latino, Hispanic, and American Indian populations. Dr. Julie E. Lucero, MPH PhD, is an assistant professor in the School of Community Health Sciences and director of the Latino Research Center at the University of Nevada in Reno. Dr. Lucero's research is centered on the identification of modifiable social determinants to reduce the impact of health inequities within communities of color and other diverse communities. Born and raised in northern New Mexico's Española Valley, known as a tricultural area consisting of largely Spanish, Mexican, and American Indian populations. She completed her doctoral work in health communication and master's in public health at the University of New Mexico. So if everybody could please help me give a virtual welcome to our guest, Dr. Julie Lucero. Welcome.
Oops. Thank you, Dr. Trujillo. I am honored to be here. It has been a long time since I've been back in the Española Valley. Virtually is just as good. So I'm really excited to be here. I wanted to just say a couple of things. So I am from Española. I was born and raised in Santa Cruz. Well, born in Los Alamos, raised in Santa Cruz, graduated from Española Valley High School, and then ended up going to Albuquerque shortly thereafter. I never really had an idea of moving out of New Mexico, but sometimes the universe has different plans for us. And so about 5 years ago, I found myself in Reno, Nevada, which is the northern part of Nevada. And it's been a really good experience. So today, let me share my screen. I'll get started. So today I'm gonna talk about the census data for health research and program planning. And I have notes, so I'm gonna be going between looking at you guys and looking at my notes. And so about a year ago, I became the director for the Latino Research Center here at UNR. And it's been an incredible experience. You know, growing up in northern New Mexico, I did not have the experience of immigration. It was so far from my experience. And so now I'm getting to know what that experience is like and learning from, you know, fellow Latinos, just with the diversity of experience, the diversity of culture, and it's just been a tremendous experience for me. So what I'm going to do in this presentation is I just have a quick agenda so that you know where we're at. I'm going to define public health and the core functions and 10 essential services of public health. We've gotten a lot of attention with COVID-19, with the pandemic. However, I think that people don't fully understand the breadth of public health. And then I'm going to talk about, just provide a brief overview of the US Census, just to provide a little bit of history and usually what the census is used for. And then I'll talk about the intersection of public health and the census. And then my final point or final 3 slides will be 3 examples of using census data. And these are 3 examples directly from my work. And if at any point, I don't know if this is okay with the organizers, but if at any point you have questions, please feel free to jump in. So defining public health. So this is a picture of CEA Winslow, and he was the leading figure in the developing of modern study of public health. And so the way that he defined it was, it's the science and art of preventing disease, prolonging life, and promoting health through organized efforts, through society, organizations, public and private communities, and individuals. So it wasn't, it was bigger, right? It's not just the individual. So like within healthcare, it's the provider-patient interaction. But within public health, it is the science and art of population health. So making sure that populations are healthy. And then it's not only just the individual health, but it's also the social situations, the social influence is external to a person that contribute to health and wellness. So then the mission of public health, there's 2 organizations, the Institute of Medicine and the World Health Organization, that are really, you know, some of the leading minds on public health. And so the Institute of Medicine says the mission is fulfilling society's interest in assuring conditions in which people can be healthy. So in about the 1990s, we started to understand the social determinants of health. And so, as I mentioned, these are the things that are external to the human condition, the human body, which influence health. And so these are things like food security, the built environment, whether you can exercise within your own community. If it's there's needles or stray dogs or things that the sidewalk's not sufficient for walking or rolling wheelchairs, for example. And then there's just a breadth of that information, the social determinants, which really contribute to health and wellness. And then the World Health Organization says their mission is that public health aims to provide maximum benefit for the largest number of people. So it's not just, those that can afford it are healthy, it's everybody. Everybody has the right to health and to health care. So then the core functions of public health. In 1988, the Institute of Medicine defined these three components: assessment, which is the systematic collection, analysis of data, and make this information available on the health of communities. So it's assessing the health of communities. And then policy development is the promotion of scientific knowledge to inform policy and decision making. And then the last one is assurance, to ensure provision of services to those in need. And so the assessment is really, to sort of summarize, the assessment is knowing what needs to be done. Policy development is being part of the solution and making sure it gets done. And then assurance is making sure it gets done, right? So this is the enforcement of policy, or the enforcement of how the data is being used. And then to finish up the first bullet point in the agenda, these are the 10 essential public health services. And so you can see in the diagram the components that make up assessment, which are the monitoring, health, diagnosing, and investigating. And informing is right on that cusp of policy development. But also mobilizing within policy development, mobilizing community partnerships, developing policies, and then assurance is that law enforcement linked to provide care, assure a competent workforce, and then to evaluate. So there's a huge network of folks that are involved in public health. And it's not just researchers or doctors, but it is, police enforcement, emergency services, nonprofit organizations, social service organizations. So it really is an immense network of people that are trying to ensure the health of a population. So then now I'm going to move into the US Census. And I'm sure up until this point, you know a lot of this, and so I'm not going to spend a whole lot of time. But one thing, we know that the US Constitution, the 14th Amendment, Section 2, says that all people that are living within the United States boundaries or borders are going to be part of the US Census. I think it's really funny. So this is in the 1860s is when this got included. And I bolded the excluded Indians not taxed. So very early on in the census, American Indians were not part of the census count. And so it ended up being that, this Indians that were not taxed, those were American Indians that were living within reservation boundaries. And so for many, many years, they weren't included in the census. And then in the 1890s, the census was the first one to count American Indians throughout the country. And then in the 1930s, the census featured an additional form that was specifically for American Indians. In the 1970s, the census was asked to include American Indians as a race. And so that was, and also tribal affiliation. And then in the 1980s, we started including Alaska Natives. And then it wasn't until the 2000 survey that, that combined American Indian and Alaska Native into one population group. And so that's when the conversion or the contemporary use of American Indian / Alaska Native was started to be used. And so, so this was just to sort of illustrate that the census is an evolving methodology, and we're still starting to see that now, you know, with the inclusion or potential inclusion of asking whether or not somebody was a US citizen, right? Fortunately, that got struck down in the courts, but it's just an illustration of this isn't, we need participation in order to maximize the methodologies of the US Census, because otherwise we don't, they're kind of do what they want to do, and we need our participation to adjust that methodology and the questions appropriately. So then here are just the regular uses of census data. And so the census data is used for apportionment, so whether or not the House of Representatives changes to match the populations of the states. Redistricting, so that's a state charge based on what the state population looks like. And then the monies that are allocated to states and localities are where public health really comes in, right? So the apportionment and all of that policy is central to all of that. But then the money that gets allocated for education, healthcare, social services, all of that is really central to public health. And so then that feeds into planning and also to emergency responses. And then the census data is the basis for federal surveys. So in public health, we rely a lot on population data sets, such as the National Health Interview Survey, the National Child Welfare Survey, the National NHANES, which is the National Health and Nutrition Survey. And these are just a few of the examples of the national survey. The other thing about the census data is it really is the denominator for health statistics, and then also the base for these federal surveys and their methodology. If it's a household survey, they can weight it based on census data. Okay, so now I'm going to move into public health and census data and what that intersection and the use looks like. So census data is the basis for a national structure, as I mentioned. And so it documents the changes to the US socio-demographic and demographic characteristics, and informs funding and planning decisions in the private, public, and academic sectors. And so the way that public health uses this data is that it monitors public health threats, such as the spread of communicable disease, because we know what the denominator is across the United States. And then it also determines the location of hospitals, clinics, and other health services should go, health and social services, once again, based on the spread of the population and where people are moving to and moving out of. And then it also identifies healthcare needs of the population, and then tries to understand the changes in mortality, disability, and fertility trends. So I want to spend a little bit of time on census tracts, because census tracts can designate diverse policy-related entities, such as empowerment zones. And empowerment zones are designated areas of high poverty and unemployment. And in these areas, they are eligible for certain grants from the federal government that are not necessarily, you don't have to pay them back, but it helps to boost the economy of the area. Another one is medically underserved areas. And these are a population to provider determination. And so if that relationship is under 62, an area gets designated a medically underserved area. And that's for dental, eye, physical, and mental health providers. And then that third bullet is qualified census tracts for low income housing credit. And so this is when 50% of households have an income under 60% of the area median gross income, or have poverty of 25% or more. And then poverty areas are defined as regions where 20% or more of the population are below the poverty line. So when these designations are met based on the census data, and this gives them opportunity for more funding that will help, right? So economics, basically economics or healthcare. And then I wanted to provide an example of what this looks like. So the map on the right side is Rio Arriba County, and Rio Arriba County has 6 census tracts. In this schematic, you can't really see it so much, but there's one towards the corner. Let's see, the bottom right corner, you can see a little 1, and then 2 is right above it. So Rio Arriba County is very large, and within that are 6 census tracts. So within those, any one of these could be one of those designated areas that I mentioned on the previous slide. But Rio Arriba County is designated a provider shortage area, and this was for primary care, and it's just short of this designation. So you can see the index of medical underservice is 61.6. And so if the population raises just a little bit more so that that number gets to 62, then it would be taken out of the designation area, or it would be taken out of that designated category. But the designation date was November of 78. So it's been there for a while. And it's interesting though that it's so high, because we know that there's so many rural areas within Rio Arriba, and the distance to a medical provider can be very large. So this surprised me that it was such a high index number. And then if you look at on the bottom in the left box, the bottom table is the designation for New Mexico. So the total primary care health provider shortage area designations, there's 109 in New Mexico. And so that means that the percentage of need that's met is only 23% of the population. And so we would need, or New Mexico would need 260 new providers in order to move the state out of a health service provider shortage area. And that's a lot, you know, so we're talking about not only increasing medical student population, but also including the number of residencies that are within the state, and then making sure that those that are trained in New Mexico or serve in New Mexico for residency stay there. And this is also true for Indian Health Service. So Indian Health Service has this opportunity where medical students can get a scholarship that helps them go through school, but then they have to give back 2 years of service. So making sure that those that have that scholarship actually stay working with American Indian nations, or at least stay in the state, stay close by. And so there needs to be, you know, some way of doing that if in fact New Mexico wanted to move out of that health provider shortage area. And this isn't unusual. Most of the rural states, so Montana, Nevada, Wyoming, a lot of those states have the same designation. The other thing that I do want to say about the census data is that it includes, you know, the numbers from the census affect every calculation and projection over the next decade for funding for these services. And so all of the safety net initiatives, such as temporary assistance for needy families, so TANF, supplemental nutrition assistance or SNAP, and then the Children's Health Insurance Program, all of those are based off of census data. So if we underreport now in 2020, we have to wait another 10 years to resolve any sort of undercounting. And the health of our populations, communities of color suffer disproportionately from health issues that if we were to undercount now, then that only helps to exacerbate those problems. So that's all the more reason for making sure that your family members, your people in your household, whether they are family or not, get counted. So now I'm on my last 3 slides, and this is to provide you 3 examples of how I use census data within my projects. So in Northern Nevada, there was actually in the state of Nevada, there was a needs and asset assessment that was conducted for the Latino community, and that was done in 2013. So one thing about Nevada is that Clark County, where Las Vegas is at, is the largest county. It has the highest population of any of the other counties. And then where Reno is at is Washoe County, and they have the 2nd largest population. So whenever an assessment like this is done, Clark County sort of takes over. And so what we know for the Latino population is that Las Vegas has a large Latino population. It's about 25%, 25 to 27, depending on what numbers or assessments you look at. But for Northern Nevada and Washoe in particular, we're at about 23%. And Elko County, Humboldt County also have very large percentages, upwards of 25%. And so what we decided to do at the UNR Latino Research Center is we wanted to see what the changes were of this population over time. And so we looked at the 2000 census and compared it to the 2010 census for the state of Nevada. And we found that there was a 35% increase in the Latino community. That's a huge number. And so really what that meant for, and it explained what we saw in Reno and Northern Nevada, was that a lot of the programs that were being developed were reactionary. And so there wasn't a chance for prospective programs. And so most of these were reactionary. And this was a result of, within Washoe County, the 24% increase of the Latino population between 2000 and 2010. And so the 2013 needs assessment that was done, first of all, it was overrepresented by Clark County, so Las Vegas. And so we really didn't know what was going on in Northern Nevada. And then a lot has changed since 2013. So there were a lot of immigration issues that have come up. The majority of our Latino population is from Mexican descent, and then South American thereafter. So what we wanted to do was really find out, given this increase, what was the lived experience, or what is the lived experience of the Latino community in Northern Nevada. So that is one way that we were able to use the census data to figure out what was going on with the population and the growth, and then to understand, where we were at now. And so for the 2010 census, we can look to see what was going on as far as demographics go, and then the behavioral risk factor surveillance survey, which is another national health survey that also provides data for Washoe County so we can see what the health outcomes are. So we can look at rates of diabetes, rates of obesity, rates of fertility, all of the health outcomes that we know the Latino community suffers from. And also what family makeup is and what the language needs are. We know that one of the social determinants of health are language needs. So whether or not families are getting translation services or interpretation services from medical programs, and social services really in general. So then the next example that I want to show you is, this was a recent program. So we at the UNR Medical School were looking to see what the outcomes of COVID were for the Latino population, or really for all communities of color. And so here on the left side of your screen is population by race, ethnicity. These are census data. And so you can see that the communities of color, so Hispanic, which is the lighter green, is about 30%. And this is Nevada-wide. For our American Indian population, it's about 1.7. Our Black African American population is about 10.3. But then when you look at that proportionally to the COVID cases, which are on your right, you can see that this pandemic, this illness, this virus is disproportionately affecting our communities of color. And this is true not just in Nevada, but all over the place. So even though, 29.2% of our population is Hispanic, the virus is affecting 45% of the cases, and these are confirmed cases, are the Latino Hispanic population. And then 1.7% of the total population is American Indian, and yet the confirmed cases are 1% that are American Indian. So it's disproportionately affecting, us nationwide, and then you can see it from these data. The other thing about in Nevada and elsewhere throughout the country is the Hispanic and Asian populations are the two that at least Pew Research has said are more likely to live in intergenerational households. What I find really interesting is that when you look at the elderly or senior population that are most at risk from COVID and dying as a result of COVID, the Latino population, the Asian population, the American Indian populations seem to be protecting their seniors much more than the white population. So that kind of, at least my interpretation is there's some value going on for our seniors and our elders. And then finally, my last slide is showing how you can use the census data to provide a rationale for youth programming. So the National Institutes of Health provides funding for research projects. And for, at least in my field, in public health and in medicine, the National Institutes of Health funding is sort of the gold standard. And in order to get that funding, you have to prove that there's a need, and that within that need, there are enough people within that population that you have access to in order to meet the statistical power that you can generalize it to either other parts of that population, right? So you can scale up to national or other states and make sure that you have, enough for power. And so here for youth programming, there was a project for positive youth development that we just submitted a grant for. This was with 3 tribal communities, 3 tribal nations here in Nevada. And I went to my tribal area, which is a part of the US Census. And you can see on the left part of your screen that you can go in and enter the tribal area. So enter the name of the reservation or reserve, or you can select it by the state, and then it'll give you a drop-down menu of the tribal areas that you can select from. And they have some additional categories that they provide data for. And so I wanted to provide you an example here. So for youth, we know that, especially for young children, you can't divorce them from their families, right? And so they don't have the autonomy to make their own decisions for nutrition, let's say, right? It's really up to the parents or the caregiver to go and buy the food and then bring it back. And so, so you have to look at the family in addition to the child. And then, so for at-risk populations, or when you're saying that a population or children might be at risk, one of the risk factors is having one parent in the household as opposed to the 2. And the rationale behind that is that one parent, if there's multiple children in the household, they can't look after all three of them the way, or multiple of them, the way that two parents can, right? And so if you look, I don't know, from the, let's see what is the best way to do this. From the bottom up, there's, you see under 18 years of age, and then the, let's see, one, two, three, four. If you go 5 lines up, there's families with female householder, no husband present. And so this isn't available for when you're looking for a city, but it is available when you're looking at tribal areas. And so this is one way to sort of to make a case of, there's 25% within this community that has the female is the head of the household, no husband present. You're sort of making the case for there's one parent as opposed to two. Therefore, you can make that as part of your rationale to say that, we need more after school programs, for example, that keeps kids occupied so that they can't go off and get into trouble, for example. Or, more after school programs for education to keep kids reading during the summer, because we know children's reading levels drop off during the summer. So, and then there's all kinds of other data within this My Tribal Area piece of the US Census page that provides, some really great data for justifying programs to any funder, not just the National Institutes of Health. So that is my last slide. And so I will stop sharing and then see if there are any questions. Sorry, that went a bit longer than I expected it to. I can talk. That's one thing that I can do.
Sorry, I'm talking to myself. I was saying that it's such dense information, so there's a lot of richness there.
Sorry, I hope I didn't provide too much.
Any questions for our guest?
I don't have any questions, but I just want to thank you for the information and for really focusing on the very importance of the census data specifically, because I think we forget that is the source of so much more, and the ripple effect of that are huge. So
yeah, thank you, Mrs. Dominguez. Yeah, it really is. We forget. And I don't know about you, but when I was growing up, and I don't think it was just the area, but when I was growing up, there wasn't really a whole lot of emphasis on this kind of thing, right? This is what you learn as you get older. And then just depending on what circles you're in, whether, to learn about the importance of this and participating, and that it's not just people that aren't from your, well, it used to be people from your community, people that were not from your community would come and knock on your door and ask, and that's changed a lot. So this changing of the methodology of the US Census, we're learning as we go, and the more diversity that we get into positions of leadership, then these things become clear, because we know, I mean, I would never go and knock on somebody's door that I didn't know, I mean, especially in, these areas that we work in, so.
Well, and unfortunately here in Rio Arriba, and there were actually 5 counties in northern New Mexico, so I'm probably not going to remember them all, but it was Taos, Mora, Rio Arriba, Catron, and one more. We kept getting a lot of mixed messages about the census, and it had a lot to do with the pandemic response, so that was understandable. But then there was this other piece where, because like in Rio Arriba County, over 97.5% of our communities get their mail at post office boxes, and the census will only mail to physical addresses. It also speaks to how we have to fight to get ourselves counted, if that makes sense. Because there's this piece where still so much of the way that this is institutionalized is imagined in urban settings as opposed to rural settings. And so we were just having a really wonderful conversation at the Census Committee today, about how do we reframe this, right? Like, so like when we say only 30% of people have been counted, that's not about blaming people for not being counted. It's saying there have been all of these insurmountable obstacles that have been put in our way. And we have to find a way to still be counted despite that, right? So what does it mean for us, even after the counting time is done, to ask for, you know, extended time to still count, or, you know, to do some kind of supplemental census collecting. And it just got into a really cool conversation amongst the leaders in the community, saying like, you know, we deserve better, we want more, and we're still going to do everything we can to be counted.
Yeah, and it, you know, I like that you pointed out we have to fight to get ourselves counted. There's really, how do I say this diplomatically? There's no reason for anybody other than us to want us to have the resources that we need, right? To be healthy, to live our best life. There's no reason for anybody else to want that for us. Like, we should want that for ourselves, right? Make sure that we have access to everything that we need. And this is one way to do that. And like I said, otherwise we're waiting another 10 years to try and get that done.
We do have a question from the chat box. And so it says, thank you, Julie. Excellent presentation. This is from Kathy Frey. Can you go into any more details on the process of using census data for the determination of location of private sector health clinics, community health centers, FQHC, and hospitals? And if you need to look at that, it's in the chat box. So you can just click on it.
Okay. Let me find my note on that.
I love that you have a note on that. Just
so first of all, the census provides the denominator for all of our risk, prevalence, and rates. And so any inaccurate counts that we have limit our understanding to track disease over time. And so demographically, when we stratify the counts and proportions, that facilitates the tracking of social determinants of health. And if we can't accurately stratify our populations by social factors, then we don't really fully understand what the relationship is. The census counts are integral to geospatial mapping, you know, all of these other things. And then population health simulations and projections require accurate counts to identify target populations or priority populations. And inaccurate counts will result in mismatches between inferences drawn and target and our priority populations. So for medically underserved areas, so the census tracts are usually between 2,500 and 8,000 residents, and they don't cross county borders. And then for the shortage areas, actually have it on this one. The shortage areas, federal regulations stipulate that in order to be considered as having a provider shortage area, the population to provider ratio must be at least 3,500 to 1. So if there's at least 3,500 residents to one provider, then that says that it's a health provider shortage area. And so that's how that designation gets created. So when there's a disparity within that health provider shortage area, and it's surrounded by other provider shortage areas, then that could be a place for hospitals. And so that's a state designation. So it's not something that the federal government does, but you can use that the census data in order to say we need one here, and then you can justify the why. I don't know, does that get at that question?
Hi, Julie.
Kathy.
Yeah, sorry, I just got done with Pilates and I don't want to show myself right now.
You're doing Pilates. You're looking beautiful, lady.
Yeah, I did it online, so it was a new experience. Virtual Pilates. Anyway, thank you. Yes, you did answer the question, and I'm just thinking about Rio Arriba County and its designation as an underserved area, and the astonishing fact that you gave about it not being updated since 1978 or something like that.
Yeah.
And access to healthcare, both in quality and in many other ways, is so important to the health of the population. So that struck me as being particularly relevant to Rio Arriba County. So thank you. You did answer the question.
Thank you. Yeah, so even going, I mean, the government or even the college really could create a relationship with the medical school, nursing school, and I think you already have with the nursing school, PA school, physician's assistant school, to bring more residents into the area. And then once, I think the Española Valley is very much like Reno. Like once you get there, it's just so stunning that why would you want to go anywhere else, right? It's just getting people to the area, and then, having them live their lives out there.
Thanks. We have one more question, and just in terms of time, this will probably be our last question. But this one's from Stephanie Montoya, and she asks, you discussed how undercounting can exacerbate a community's health issues since the census is used to determine allocation of resources. But do you think that a community's census response rate is in and of itself an indicator of public health? And if so, how could this be studied?
That's a great question. So I firmly believe that the lack of response is an indicator of public or government mistrust. And so that could very much be an indicator of public health, right? Whether or not communities trust, if public trust is not there, public mistrust is there, then we can also make the inference that mistrust of medicine and medical doctors is also present, which in that case, people aren't going to go seek services for medical providers. I remember when I was, and everything, I'm just going to stipulate this. I'm a trust researcher. I believe that trust is at the center of really everything that we do, trust and culture at the center. So everything to me comes back to trust. So I should have warned you about my answer before I started. But we know that when I was growing up, I remember my grandma saying, don't go to the doctor, they'll just find something wrong with you, right? She said that all the time. And so to me now, looking back on that, it was a mistrust of maybe not the medical doctors themselves, like, questioning whether they knew what they were doing, but about the medicine as a business, right? So that the medical debt piece of it, that they're going to find something wrong with you so that you have to keep paying out. And so if you think about whether or not people are going to go to the doctor if they're sick, or if they're going to find some other remedios, just to until it gets so bad that they have to go, then that is definitely an association and an indicator of public health, right? Because then people aren't going for preventive medicine, they're going when they're too sick to maybe get better, or that preventive medicine is gone by the wayside. And now we're looking at secondary and tertiary care. So yeah, I think that it's an indicator of public and government mistrust for sure.
Wow, thank you. If everybody could unmute themselves and help me in giving a round of applause to our speaker. We really thank you, Dr. Lucero, for coming back home and sharing.
Thank you.
It is my absolute honor. Thank you so much for letting me come back and provide some information. And of course, if there are any questions, I can let me put my contact in the chat box. And then if anybody has any questions, please reach out.
Thank you so much. And in closing, I just want to remind everybody that there's one last, we're calling it the Fiesta, the Census 2020, because we didn't get to have our annual fiestas in our communities this year. And so you can go through some drive-through fiesta events. And this weekend, on Saturday, the 25th, the Habitat for Humanity in Española, the Restore is hosting an event. And it's open. It starts from 11 to 5. They're going to have food and socially distanced entertainment. But from 11 to 4, I believe, if I'm remembering, no, 11 to 1, I'm sorry, there will actually be census workers there. So if you want to go out, get some gifts, get some food, you can also fill out your census on the spot, and it's a win-win-win. And also Habitat for Humanity will be is looking for volunteers. And so with that, I really want to honor the work of one of our community members, Miss Willie Williams, who is the facilitator for the Black and African American Student Organization at Northern. And she helped to organize a PSA that I will be sharing with everybody now in closing. So I just want to say thank you for coming, and enjoy this PSA featuring some Northern students and basketball players.